Imagine going into a clinic for like a quick 30-minute procedure, just for store some lost tissue volume, and then walking out with a complication so severe that it permanently starves your tissue of oxygen.
Yeah, it's a really stark reality.
It is. Welcome to the Deep Dive, learner. Today we're basically stripping away the intense secrecy and the whole taboo surrounding one of the fastest growing, but also most private procedures in the clinical world right now.
Which is fascinating because the landscape of cosmetic gynecology is undergoing a massive shift. I mean, for decades, the entire aesthetic industry was hyper-focused on visibility.
Right, the face, the neck.
Exactly, the hands, things the world can readily evaluate.
Yeah.
But intimate wellness, meanwhile, was just blanketed as profound silence.
Yeah.
And that left a massive gap in patient education.
Which is crazy when you think about the real, functional implications of these changes. So we're diving into the clinical realities of the labial puff or labia majora augmentation. And we've got a fantastic stack of sources today. We're looking at clinical surgical guidelines, data from the British Association of Aesthetic Plastic Surgeons, the BAPS, and some really critical FDA safety reviews.
Lots to cover.
Definitely. Our mission for you, the learner, is to answer a highly specific question today. What is the biological and clinical difference between plumping that tissue with synthetic hyaluronic acid fillers versus using your own body's fat?
But before we compare the actual materials, we really need to locate the exact canvas we are working on because the terminology in this space often gets totally tangled up by marketing.
Yeah, just to be crystal clear on the geography here, we are exclusively talking about the labia majora today, right? The outer hair-bearing cushion, not the inner menorah that people usually associate with, like a surgical labiaplasty.
That distinction is paramount, yeah.
Yeah.
The labia majora act as a biological shock absorber for the vulva, and over time, they endure some really significant physical changes.
Like what, exactly?
Well, massive weight loss, the intense physical trauma of childbirth, and especially the severe hormonal drop during menopause, all of that can cause that protective tissue to deflate, thin out, and just sag dramatically.
And losing that shock absorber, it isn't just an aesthetic issue, right? Where someone feels self-conscious in a bathing suit. The sources point out that this causes severe functional pain.
Oh, absolutely. The psychological and the physical toll is immense. Women report acute pain during everyday activities. I mean, horseback riding, cycling.
Just sitting at a desk.
Exactly. Just wearing tight jeans or sitting for long periods becomes agonizing due to the lack of padding, not to mention the severe discomfort it can cause during intercourse. So restoring volume to the labia majora is very frequently a functional pain-relieving intervention, even if clinics market it under a cosmetic umbrella.
Okay, let's unpack this, because the clinical dichotomy we're looking at is just wild. On one hand, you have a quick lunchtime clinic visit using a synthetic gel, and on the other, you have this...
Two very different worlds.
Right. Let's start with the non-surgical route. Hyaluronic acid or HA fillers. How does someone just, walk in and get that done?
So the patient receives a local or topical anesthetic in an office setting. The practitioner then uses extremely fine needles, or sometimes a blunt-tipped microcannula, to inject a specialized HA gel directly into the subcutaneous layers of the labia majora.
Wow, okay.
And the entire procedure is over in like 15 to 30 minutes.
That fast. Now, HA is everywhere in skincare right now, and it's not some alien chemical. I mean, our bodies naturally produce hyaluronic acid in our skin, our eyes, our joints.
Right.
But how does injecting a clear gel actually create lasting volume? It's not like the gel itself is taking up all that space, is it?
No, not at all. HA operates like a microscopic biological sponge. It is incredibly hydrophilic, which basically means it loves and attracts water. So once it's injected under the skin, those HA molecules bind to ambient moisture in the surrounding tissue, and they end up holding many times their own weight in water. That targeted hydration is what creates an instant plumping and smoothing effect.
So it's essentially inserting temporary microscopic water balloons under the skin.
The water balloon analogy works beautifully, yeah, because the volume relies on the localized fluid it traps, rather than just the physical mass of the gel inside the syringe.
Okay, that makes sense. Now, there's a specific brand mentioned constantly in these clinical guidelines, Deserial, made by a company called Vivacy.
Yes, very common in this space.
Right, and they have a product called Deserial Plus that's formulated specifically for the intimate area. And what stood out to me is what they mix into the syringe. It's not just the HA sponge. They include an antioxidant called mannitol.
Right, mannitol.
which is found naturally in, like, raspberries and celery. One, if we know the body is just going to slowly break down this HA filler over time anyway, why are we injecting a raspberry antioxidant? Isn't that just delaying the inevitable?
Well, it is delaying the inevitable. But that delay is the entire point of the formulation. You see, the human body is highly reactive to trauma.
Even from a tiny needle.
Oh, absolutely.
Hmm.
The moment a needle pierces the tissue, it triggers an immediate inflammatory cascade.
Yeah.
The immune system rushes in, releasing free radicals as part of the healing response.
Which are basically unstable molecules that damage nearby cells, right?
Exactly. And they immediately start attacking and degrading the newly injected hyaluronic acid before it can even, settle into the tissue.
Oh, wow.
So the mannitol acts as a free radical scavenger. It essentially sacrifices itself, absorbing the brunt of that inflammatory attack so the HA gel can survive those crucial first few days.
That is wild.
And crucially, mannitol also severely limits the post-procedure swelling. In an area as highly innervated and sensitive as the vulva, minimizing acute, rapid swelling is absolutely paramount for patient comfort.
Okay, but even with the mannitol bodyguard, those microscopic water balloons pop eventually. The clinical data shows results are immediate, but they max out around 6 to 12 months, right?
Yeah, maybe pushing 18 months in the best case scenario.
Right. And the guidelines explicitly say doctors shouldn't inject more than 20 milliliters per year. Your body just constantly metabolizes the sponge.
The metabolic breakdown is continuous, yes.
Right.
So to maintain the functional cushion and the aesthetic result, the patient is required to return annually for top-up injections.
It's a continuous cycle of maintenance. I look at it like leasing your results.
Leasing, yeah, that's a good way to put it.
It's lower commitment up front, but you have to keep paying the maintenance fee. But the undeniable upside to these HA water balloons is the safety net. If you hate the result or if it feels weird or asymmetrical when you're cycling, it's not a permanent mistake.
No, not at all. The reversibility is a massive draw for patients who are hesitant about aesthetic procedures. Practitioners can just inject a specialized enzyme called hyaluronidase.
And that just melts it.
Pretty much. This enzyme rapidly cleaves the bonds of the hyaluronic acid. Within hours, the gel dissolves entirely. The trapped water is released and flushed away by the lymphatic system, and the tissue returns to its baseline state.
Wow. So if you're someone who loves the volume but hates this cycle, the constant top-ups, the annual clinic visits, your body actually offers a permanent alternative.
It does.
So it requires going under the knife. So let's look at autologous fat transfer, using your own fat.
Right. So autologous fat transfer, clinically known as lipofilling, is a much more involved three-stage surgical operation. Stage 1 is extraction. The surgeon uses microliposuction to gently harvest fat cells from a donor site, which is typically the lower abdomen, the flanks, or the inner thighs.
And I assume they don't need a massive amount. We aren't talking about a full-body contouring liposuction here.
No, usually only a small volume of fat is needed. The incisions are minute, around 3 millimeters. But the raw material harvested in that syringe is this chaotic mixture of intact fat cells, blood, tumescent fluid used for numbing, and broken cellular oil.
Okay, sounds messy.
It is, which brings us to stage 2, processing.
Right. The sources mention spinning the fat in a centrifuge. How does that separate the viable fat from the chaotic mixture?
Well, a centrifuge spins the syringe at a really high velocity, creating immense gravitational force. Because the components of the mixture have different densities, they rapidly separate into distinct layers.
Like oil and water.
Exactly.
Yeah.
The heavy blood and numbing fluid sink to the bottom. The lightweight, broken oil from dead fat cells floats to the top, and the surgeon is left with a pure, golden middle layer of highly viable, intact fat cells.
Okay.
And then stage 3 involves carefully injecting those purified cells into the labia majora.
And here is where the sources completely blew my mind. Because this isn't just organic filler. It's not just moving dumb volume from your stomach to your labia. The clinical papers keep highlighting this element called the stromal vascular fraction, or SVF.
Ah, yes. The stromal vascular fraction is the true biological powerhouse of fat transfer. Adipose tissue fat isn't just passive energy storage. The SVF is a dense concentration of adult stem cells, growth factors, and endothelial cells.
Right. So by injecting this purified fat, you are basically injecting a localized healing serum.
Fundamentally, yes. When introduced to the labia, these stem cells trigger angiogenesis, which is the biological formation of brand new blood vessels.
Wow.
They aggressively promote tissue regeneration. The clinical outcomes show profound improvements in tissue elasticity, hydration, and overall cellular health.
The sources specifically noted clinics using this to soften and repair dense scar tissue from episiotomies during childbirth, or even regenerating tissue that has been completely thinned out and damaged by radiotherapy for pelvic cancers.
It's remarkable, really.
That is incredible. It's biological tissue repair masquerading as a volume boost.
It changes the microenvironment of the tissue entirely. But we do have to note that the transfer process itself is biologically brutal on the cells.
Right, the catch. The cells don't all survive the trip. The literature states explicitly that 30 to 50% of the transferred fat will die and be reabsorbed by the body in the first 3 to 6 months. Why is the death rate so high?
Imagine those newly injected fat cells holding their breath. They have been stripped from their original blood supply in the abdomen.
Okay.
When they are injected into the labia, they are entirely reliant on the surrounding tissue fluid for oxygen and nutrients until new blood vessels, that angiogenesis we just talked about, can reach them.
So it's a race against time.
Exactly. The cells that suffocate before a blood vessel hooks up to them will die, break down, and be cleared away by the immune system.
So surgeons have to overcorrect. They have to overfill the labia majora during surgery, fully anticipating that half of it is going to suffocate and disappear.
Yes. The immediate postoperative result will look exaggerated and swollen. The patient really has to trust the surgeon's math and wait several months for the final, settled outcome to emerge.
Here's where it gets really interesting. Once that surviving 50% establishes a blood supply and starts breathing again, we call the result permanent. But the sources warn that permanent does not mean static. Because it's living tissue, it acts like living tissue.
Very true. The surviving fat cells retain the genetic memory of their donor site.
Wait, really?
Yeah. If they were harvested from the abdomen and the patient has a genetic predisposition to store weight in the abdomen, those labial fat cells will expand proportionally if the patient gains weight globally.
That is so weird. It's exactly like planting a tree in a new yard. You dig it up, you transport it. Half the branches might die from the shock of the transplant. That's your 30 to 50% resorption from suffocating.
Right.
But the roots that actually take hold in the new soil, they are permanent. However, that tree is still going to grow or shrink depending on how many calories you feed it over the next 10 years.
That analogy captures the biological reality perfectly. Long-term predictability of the outcome relies heavily on the patient maintaining a relatively stable body weight.
So we have the temporary synthetic water balloons that slowly dissolve and the permanent living tree transplant that fluctuates with your weight. How on earth are doctors and patients navigating this choice? What are the hidden dangers tipping the scales?
Well, the clinical guidelines reveal a pretty sharp division in medical opinion, and it's driven largely by complication profiles and practitioner specialty.
Yeah, I noticed Dr. Karen Leong in the American Society of Plastic Surgeons data. She is very vocal about avoiding HA fillers entirely for the labia puff.
Yes, she is.
She prefers fat transfer or biostimulatory fillers. Wait, what is a biostimulatory filler? Is that different from the HA sponge?
A biostimulant operates on a completely different principle. Instead of holding water like HA, a biostimulatory filler contains microparticles that cause a controlled, low-grade irritation in the tissue.
Irritate.
Yeah, this irritation tricks the body's immune system into rushing to the site and producing massive amounts of its own natural collagen to wall off the particles. So the volume comes from your own newly generated collagen over several months rather than the immediate presence of the product itself.
Got it. But why is a highly trained surgeon like Dr. Leong rejecting the convenient walk-in HA option?
She points to the high incidence of granulomas and hard nodules. The labia majora is subjected to intense, repetitive friction and pressure from walking, sitting, tight clothing. Over time, that mechanical stress can cause the HA gel to clump together.
Oh, that sounds awful.
It is. The immune system recognizes this dense clump as a foreign invader. It can't break down fast enough, so it walls it off with thick inflammatory tissue, creating a painful, hard lump known as a granuloma.
And it's not just localized lumps. The safety documents detail the standard dermal filler risks, allergic reactions, infections, and filler migration, where the gel actually travels away from the injection site. But the absolute nightmare scenario mentioned across every safety review is vascular occlusion.
Vascular occlusion is a catastrophic medical emergency. It occurs if the practitioner accidentally pierces a blood vessel and injects the thick HA gel directly into it, or injects a large bolus of gel so close to a vessel that the external pressure pinches it shut.
Oh.
The blood flow is instantly blocked.
And when the blood stops?
The tissue downstream is immediately starved of oxygen. Necrosis tissue death begins rapidly. I mean, in facial fillers, this mechanism has caused permanent blindness and strokes. In the vulvar region, an occlusion can lead to massive, agonizing tissue death and irreversible disfigurement.
Which perfectly explains the stark warning from the FDA. They actively recommend against using dermal fillers for unapproved body contouring.
They are very clear about it.
The FDA explicitly calls out breast and buttock enhancement as off-label and highly dangerous. While they don't single out the labia by name in that specific list, the biological warning is the exact same. Pumping large volumes of synthetic gel into the body carries unpredictable risks.
Exactly. It requires a medical professional who knows the deep vascular anatomy and has hyaluronidase drawn up and ready to dissolve a blockage the second the skin turns white from lack of blood.
Right.
The walk-in, walk-out marketing of fillers breeds dangerous complacency. Patients start viewing them as casual beauty treatments akin to a facial, leading them to, unregulated med spas.
Yeah.
The BAPS safety review is adamant that these severe complications can only be managed safely in strictly regulated clinical settings.
But let's be real, the surgical route with fat transfer is not exactly a spa day either. You are choosing to have surgery. You need local or general anesthesia. You're looking at 3 to 5 days off work and absolutely no strenuous exercise, horseback riding, or intercourse for 4 to 6 weeks.
The surgical risks are substantial. You have donor site complications, bruising, contour irregularities, fluid buildup where the fat was harvested.
Right.
And in the labia, if a large pocket of injected fat fails to vascularize and suffocates, it doesn't always just absorb quietly.
Yeah.
That dead fat can calcify or turn into firm oil cysts under the skin that might require surgical removal.
Ouch.
There is also the constant risk of asymmetry, where the left side successfully absorbs 60% of the fat, but the right side only absorbs 30%. And then you need a secondary touch-up surgery.
We also have to address the extreme worst-case scenario here. The BAP's review dedicates significant ink to fat embolism. Now, they were primarily discussing this regarding the Brazilian butt lift, the BBL, but the biological mechanics are identical for any fat transfer, right?
The mechanism of injury is identical, yes. A fat embolism happens when the surgical cannula accidentally tears a deep vein and fat is injected under pressure directly into the venous system.
And where does it go?
That fat travels back to the heart and is pumped into the lungs, creating a pulmonary embolism, or it travels to the brain. This is a rapidly fatal event.
Terrifying.
In the early days of the BBL boom, the mortality rate was catastrophic, around 1 in 2,500. By revising guidelines to restrict injections strictly to the superficial layers, that risk has dropped to about 1 in 15,000. But the systemic risk is never zero.
So even though a labial puff uses a tiny fraction of the fat a BBL uses, and the pelvic venous anatomy is entirely different, you're still blindly driving a metal tube beneath the skin.
Exactly.
If that tube deposits fat into a torn vein, you are looking at systemic failure. It just underlines why an esthetician cannot do this. You need a board-certified surgeon who understands exactly what layer of tissue they are in.
The foundational takeaway for patient safety is universal. The instrument, whether it is a syringe of hyaluronic acid or a cannula of your own fat, is only as safe as the practitioner wielding it.
So what does this all mean? If you are the learner sitting in a consultation chair, you are staring down a very distinct, very personal trade-off.
You are. You are weighing immediate convenience against biological permanence and the specific risks of synthetic gels against the traumatic risks of surgery.
If you opt for the HA fillers, you are choosing a fast 30-minute procedure with virtually no downtime. You get instant relief from that functional pain, and if you hate it, the enzyme eraser is right there. But you are signing up for a lifelong maintenance cycle. You'll be back every 12 months, paying repeatedly, and accepting that rare but severe risk of vascular occlusion every single time that needle goes in.
Conversely, autologous fat transfer demands a high upfront commitment. You must endure liposuction, weeks of physical restriction, and the unpredictable math of cell survival that might leave you asymmetrical.
But you get a living, breathing result. You harness the incredible regenerative power of those stem cells repairing your damaged tissue from the inside out. And barring a major weight fluctuation, you get a permanent structural fix. You plant the tree, and you are done.
The right choice relies entirely on the patient's individual anatomy, their tolerance for surgical downtime, and whether their primary goal is just a temporary volume boost or a long-term regenerative repair.
And that fulfills our mission for this deep dive. We've stripped away the taboo to look at the hard clinical realities of restoring labial volume. Neither HA fillers nor fat transfers are flawless miracle cures. They command immense respect for human anatomy.
They really do. The functional relief these procedures provide is profound, but achieving it safely requires profound medical expertise.
Absolutely. But before we sign off, I want to leave you, the learner, with a final lingering question to ponder based on what we've uncovered about the biology of fat.
Oh, I like where this is going.
If autologous fat transfer isn't just about moving physical mass, if that stromal vascular fraction physically regenerates aging, scarred, or radiation-damaged tissue by triggering new blood vessels, could our own unwanted body fat actually be the ultimate untapped anti-aging medicine hiding in plain sight?
It's a huge question.
What else could we heal simply by moving our own cellular material from one part of our body to another? Thank you for joining us on this deep dive. Stay curious, ask the hard questions, and keep learning.